Fred has extensive clinical and research experience with Alzheimer's disease and related disorders. He's been a leader in the field for many years and has many accomplishments, but just to name a couple things, areas that he works in, some of you may know that he helps develop widely used cognitive and clinical outcome measures for AD clinical trials. And some of this work he did in service or with the Alzheimer's Disease Cooperative Study here, headquartered here at UCSD. In fact, he was one of the early people developing cognitive scales in the early days of the ADCS. He's also a leading expert on neuropsychological assessment of individuals with Down syndrome and leads some of the largest and most well-known studies on cognition and Down syndromes in the country. And the last thing I want to mention, and one of the reasons we asked him to present here, so he's published extensively on brain behavior associations and neurological diseases with a focus on differential diagnosis and early detection of Alzheimer's disease and other disorders. And much of that work he did at the with the Sanders Brown Aging Center and with the Alzheimer's Center in University of Kentucky. And he was fortunate enough, I'm sure he'll say, to work with some of the leading pathologists in Alzheimer's disease. First, Dr. Bill Marksbury, and more recently with Pete Nelson. So I believe you're going to focus on that research in your talk today, and your talk's entitled Alzheimer's Disease Mimics, Clinical Course and Pathologies. So thank you, Fred, and take it away.
Thank you, David. That's a very kind introduction. Let me see. We'll start out with disclosures. Always important to make sure that everything in the world is crisp and clean. Currently, there are no disclosures. There's no conflicts of interest, unless one would argue that being funded by NIH on a number of projects leads to conflict. But the good news is that there are none. Perhaps 10 years ago, I would have had to list some of the pharma clinical trials. What I'd like to do today, just to kind of introduce you to my thinking, and the good news is now that I'm giving the talk, I don't rearrange my slides, I don't add slides, and you'll find probably that I have too many slides. But having been in the field for years, having started my interest in Alzheimer's disease back in the early 1980s, when I did my fellowship at Duke with Al Heyman, Alan Roses, and a number of other people, we did some early clinical trial work, which led me to meet Leon Thal of the ADCS fame. And there was a directors meeting in the early days of the first 10 Alzheimer's centers that was held in San Diego. I think it was the first directors meeting, and I had the privilege and pleasure of meeting Bob Terry and Bob Katzman and being able to discuss some of their work, some of the early neuropathologic work that was being done. And from there, began to become a curmudgeon and as grumpy as I possibly could be, because I couldn't do all of the neat things that they could do. They were just too talented. But what I'm going to talk about is what we talked about in those days, based on observing patients in clinic, was what we called the slow form of Alzheimer's disease. And I think we're beginning to open a new window on describing what this slow form of Alzheimer's disease is. It's actually probably a different entity, even though it involves some of the components that we see in Alzheimer's disease. So I'll talk a little bit about the cognitive course of progressive age-related tauopathy, or PART, and then late, which I always butcher, with and without hippocampal sclerosis of aging. And late is the limbic associated tauopathy, the TDP-43 encephalopathy. And then I'll throw in some data on the neuropathology there, And then I'll get into some of the work that our talented group of biostatisticians has been doing based on the data that we have collected over the last 35 years, particularly the neuropath data. So it's always nice to remember those early days in San Diego. I remember the meeting being in a Holiday Inn that was situated on the beach, and we had to close the curtains because all of us who were landlocked, like here in Kentucky, we spent most of the meeting staring at the beach and the water and paying less attention to the discussion until we wisely closed the curtains. But the key is that with aging, and I think Mark Twain, the reason I use this slide is very fascinating, is this notion of remember the things that never happened. And that is some of the early work that was done that I did in what I would call recognition failure. And that was based on some work in the early days of clinical trials with Dr. Thal, which showed that in Alzheimer's disease, we actually had more intrusions of information that was not to be remembered, and we had a failure by individuals to recognize that information that they had learned. Now, everybody knows this. I'm going to go through these couple of slides quickly, but I think the history is important because it highlights the plaque and tangle and the associated proteins, the beta amyloid and tau. And part and late are going to be much more tau specific rather than what we traditionally think of as Alzheimer's disease. And I'll show you more data. But there's a paper that is now 20 years old. So it's like a good wine. It hopefully has gotten better with age. But in 1988, we established a cohort for mainly autopsy purposes to compare normal aged individuals to Alzheimer's pathology. At the time, we had just started our Alzheimer's disease center, and we're seeing patients with Alzheimer's disease and obtaining autopsy from them. We were also obtaining autopsy tissue from the Alzheimer's Association, as we were a regional autopsy center. And so we chose at the time, there was a program project grant that was looking at oxidative stress and heavy metals in the brain. And we decided we needed people to come in who aged normally without disease and use that tissue for comparison so that we could study the Alzheimer's pathology and the related mechanisms. And this was a program project grant led by Bill Marksberry, among others. And after we had the first 100 autopsies, and a lot of the work, autopsy work was done by Darren Davis, who later went into private practice, sadly, we took a quick look at what does the neuropathology of cognitively normal older adults appear to be. And what was fascinating is we saw plaques and tangles. And again, this is no surprise now, but back then, the degree of plaques and tangles that we were seeing in people who were resistant to the Alzheimer's pathology was fascinating to us. We also at the time saw a lot of cases where, how shall I put it? We saw, I'm trying to get my little laser here, but I'm not seeing it. Let me see if the spotlight will work. We were seeing that there were people who were showing these increased numbers of tangles, but remained essentially cognitively resilient. And Bill Marksberry coined the term successful cerebral aging. But what's fascinating is we were seeing those changes in some of the classic areas where we see early Alzheimer's disease. And as time goes on, as you all know, this became quite relevant to what we now know is mild cognitive impairment, as well as early or prodromal Alzheimer's disease. And it looks like that annotation is going to stay. Sadly, I should have known better. Let's see if this gets rid of it. So you all know about the classic theory from Cliff Jack of changes in the neuropathology, amyloid first, then tau, then neuronal loss, and then the cognitive and behavioral changes that we see in Alzheimer's disease. But what's fascinating, and it's good that this stayed in place, is that we can see the atrophy in the hippocampi, both in amnestic MCI and in AD. And this was seen as a classic hallmark. And some of the early stuff for 2 years looking at hippocampal atrophy, you could predict Alzheimer's risk. Later, I'm getting an unstable internet connection, so hopefully I won't be kicked off. As you know, great biochemistry has led to major advances in the field with imaging, where we can now get amyloid in the brain and we can get tau. And this will become important, I think, as we begin to study these early memory changes that occur in these slow forms of Alzheimer's disease. I just love this cartoon. I've used it for years. I hope you enjoy it, because that's kind of how people get worried. When I see people in clinic, they're worried about their cognitive change and in particular their memory. And I always ask them, what is it you're forgetting? The old rubric when I did I actually did a 1-year psychiatry fellowship at Duke, was that people who came in complaining about their memory were likely to be depressed. And it took years for us to realize that that is not the case. It often is a prodrome for mild cognitive impairment and early Alzheimer's changes. And now, if you will, these other forms of tauopathy that we see in our autopsy cohort. And what's fascinating about this is that it's taken years for people to get into this subjective cognitive decline concept and try to study this in greater detail. Hence, the subjective cognitive decline working group that was formed through APIA in the Alzheimer's Association. And what's fascinating about this is there are large-scale studies that have looked at this and looked at the risk that this early subjective decline provides for the development of MCI and dementia. And dementia here I'm using as a general term. And there's a beautiful study out of Leipzig, Germany, and over 1,000 older individuals aged 75 and older who were asked, are you noticing a decline in your memory? Yes or no? That's the none group that says no. And if you say yes, does it worry you? Is it affecting you? Versus those, well, it's there, but I'm still getting along fine. What's fascinating about that are the proportions, as you can see, that over 50% have this subjective memory impairment, or SMI, or subjective cognitive decline. And you can see the hazards. If the worry is there, 3 to 4 times the risk of developing MCI and dementia. And what's fascinating about that is, and sadly, if you can still see the red line like I do, I apologize. I don't know exactly how to get rid of that unless I close and reopen, I guess. And if it gets annoying to anybody, let me know and I'll close and reopen the PowerPoint. But what we see is those with no worry, their dementia risk hazard is low. Those with normal, no worry, and with worry. And you can see that in a 4-year time interval, that risk is very notable. And if you look at other studies where people have looked at subjective cognitive decline and dementia risk, like the Nurses' Health Study or our large prevention trial that we did a few years ago, looking at antioxidants in about 7,000 men, the pre-advised trial, and our own cohort, which is no longer called the brains cohort, but I like it because one of our volunteers labeled the group, the biologically resilient adults in neurologic studies. And you can see that in older adults, these subjective memory concerns are very significant and they're very prevalent. What's even more fascinating is studies that have come out looking at people who are at risk for dementia due to family history. Here's a study from Wisconsin, the ADRC there, and they looked at 261 adults, as you can see, of which 77 had the complaint. Something was wrong with memory. And Sterling Johnson and colleagues did some imaging and found, interestingly enough, no surprise to those of you who know about memory functions and structures, that the key was the entorhinal cortex, as well as posterior cingulate, as you can see here. Sorry, it's allergy season. And to find those differences in those structures in people who are complaining about change really opens the door to that prodromal change that's involved in memory loss. Just a quick review of memory systems. Those of you who are not as familiar with memory systems, you can see from the original Budson and Price paper which structures are involved. What's even more fascinating is if you come over here to the bottom right and you look at the hippocampal structure and dentate gyrus, CA1, CA2, and CA3 regions, it tells us something about what's happening in these tauopathies. A lot of interest in Alzheimer's disease has always looked at the CA1 region for tangle formation. What I'll come to in a little bit is that CA2 is also important. And interestingly, CA2 is being implicated in social memory from a number of studies. But bear in mind that cartoon, if you will, of the hippocampus as we move into this region. There's a great study from France that looked at imaging of the hippocampus in people with the subjective decline. And you can see the structures of the hippocampus here in this cartoon. But what they did is they compared subjective cognitive decline, the individuals who had it against those who didn't. And lo and behold, they're seeing bigger changes, the orange and red, in those regions that fit the CA1 region. But also, if you take a careful look here, you see that CA2 may be involved as well. And in fact, our own work from our cohort shows that there is impaired memory that goes with this subjective cognitive impairment when you do formal testing and detailed testing. And what you see is those who don't have impairment tend to have low AD pathology. This is based on the old NIA Reagan criteria of plaques and tangles counts. And very few, as you can see here, who are unimpaired but have a complaint are not showing a pure AD picture. But a good 40% or so are headed in that direction. They have these intermediate Alzheimer pathologic changes in brain. Those who show impairment, who never become demented, however, show lots of AD pathology. So the high AD pathology group, you can see that 15% increase. And here you see it almost doubling of the intermediate brain pathology. And we published this a number of years ago based on our brains group. So the pathology is there. And the question is what's happening with these proteins in the brain? I won't belabor this. There's a lovely review by Kurt Jellinger, a good colleague from Vienna, that talks about the Alzheimer's continuum using the ATN or amyloid tau neurodegeneration framework, which has been around now for about 6 years or 7 years. And he talks about what are our biologic markers. But what's really of interest is this group right here, this amyloid negative, tau positive, neurodegeneration negative, or neurodegeneration positive group, which is here at the bottom. And that's where our progressive age-related tauopathy pops in. And Kurt does a nice job in this review, if you will, of all of the literature. And the key is, as you can see in the blue, these are the two that I'm going to talk about a little bit more. So there was a large-scale study that was done across 21 centers who had autopsy material. And what they did was, and this eventually led to a position paper a number of years later about progressive age-related tauopathy. And what they did was they looked at the neuropathology and said, we can break this down into stages, if you will, based on the Braak staging. Braak staging being, if you will, the degree of neurofibrillary pathology that you can see in the entorhinal cortex and the hippocampus. And what you have is you have essentially a scoring that says you have no amyloid, but you have tau pathology. No or low amyloid, I think, is a safer way to put it. And you can then partition, if you will, no pun intended, your findings into whether or not the person has this primary age-related tauopathy. And what happens is fascinating is that once you get to beyond Braak stage 4, you start seeing more A beta pathology with it. So part seems to be this subtle, if you will, buildup of tau in the hippocampal and associated structures that leads to memory loss, but does so rather slowly because in part the amyloid pathology is not driving this. And so we have this lovely way of classifying this condition. And there's a lovely paper out of the national data set, the NAC data set, that looked at what are the cognitive changes that come along with PART. And this is something of interest because when we talk about that slow form of Alzheimer's disease in older individuals, we've always clinically seen the memory change continue, but haven't really appreciated a lot of other changes. And in particular, we haven't appreciated that functional change that kicks into a dementia classification. But we see it in older people. We always said that, you know, people in their 80s were the ones most likely to have this slow progression of memory loss. And what's fascinating about this, and I know Dr. Salmon is an expert in this area, is that the data suggest that there are very real differences between these PART patients, if you will, or cases, and those with AD, regardless of the severity of dementia. And in fact, you see sparing of semantic memory and language that is kind of a hallmark of the progressive age-related tauopathy compared to what you would see in Alzheimer's disease, hence those red boxes. And interestingly, in the more advanced stages of the two conditions, you still have sparing of semantic memory and language along with attention in these individuals because the pathology is so focal, if you will, in the hippocampal structures. And this leads to some thoughts and hypotheses about ways that we could clinically identify these individuals with PART and with late. And I'll get to that in a little bit. The nice thing about the NAC analyses is you can even see the rate of change fits that concept of the slow form of Alzheimer's. if you look at the progressive age-related tauopathy slopes here for these composite indices out of the NAC cognitive assessments, you can see that patients with Alzheimer's disease show a much more dramatic change over time in all of their functions, if you will. Global, the mini-mental, the visuospatial, almost no change in the part cases. And eventually language does change, but not at the same rate as you see in Alzheimer's. And memory remains fairly unaffected over time, but does progress. And I think this is fascinating in the sense that if we could use this information to generate cognitive indices and combine them with the new imaging technologies of amyloid and tau PET, we could theoretically diagnose these individuals early on. And as we develop therapies for tauopathy, we could actually make a major impact on quality of life for these individuals in their 80s and older. Here's the frequency. They looked at the neuropath that was in the NAC data set, and you can see, and I apologize for the fact that they had a small figure, but you can see most of the tangle and tau pathology is in the entorhinal cortex, the hippocampal CA1 region, and subiculum with some transentorhinal, but the rest of the regions are less affected. So this leads to a very focal, if you will, hit on the episodic memory system. Now, there's a paper that just came out, and this is the challenge in doing talks like this. You find neat new stuff that came out since the last time you thought about it. And again, based on the neuropathology from a large sample of autopsies, those who have part versus ADNC, which is the standard Alzheimer's nomenclature, you see that there is a difference in tau or tangle formation in the CA2. In fact, they created a ratio to express the difference in part versus AD. So the fact that we've been looking at CA1 all these years in AD is relevant to how part actually appears. And you can see the table underneath, and I provided the slides so you can look at them in more detail, that you can see again that stage 4 level, that's where you see definite part and the possible part, but the Alzheimer's patients tend to be stage 5 plus. And so there's something unique about this tauopathy, and that in and of itself is worthy, I think, of study. So we have a good picture of part. We've got lots of data from the religious orders study, our colleagues at Rush, Dave Bennett, Bob Wilson, Julie Schneider, to mention a few, who've done a lot of work in this. And Julie and the crew, Julie Schneider at Rush, have had an R01 to study part in those religious orders and memory and aging project cohorts that they have in Chicago. But let's switch to late, because it's another form of the slow form of Alzheimer's disease. And here now we have discovered a new, if you will, marker of hippocampal sclerosis. We see this tar-derived protein depositing in the mesial temporal lobes, and the hippocampus is sometimes sclerotic, sometimes not. And this harkens back to the discussions we had in San Diego all those years ago, where we were looking at autopsy tissue and finding individuals who were older, 80, 75, 80, 85 years of age, and they only had the tau deposition. So we looked at it as kind of a tau-only phenomenon, but really didn't know what was driving it at the time. And a lot of that research also was replicated in the Honolulu adult aging study, where we would see this tangle-only dementia, if you will. And we would look at a lot of our autopsies and say, boy, that hippocampus looks shrunken. But we would also see a lot of tauopathy in hippocampi that weren't sclerotic, if you will. And again, the term, I think, late came about because when you talk about hippocampal sclerosis, people think of epilepsy as well. In our own epilepsy center, while we're evaluating patients for intractable epilepsy, we do structural MRI that shows often a unilateral hippocampus that is sclerotic and is the site of the seizure activity, and is eventually, if they're refractory epilepsy cases, it's resected. So when we first, I think Pete Nelson first coined that phrase, hippocampal sclerosis of aging, and you'll see that in our early papers. There was a bit of confusion. This is what we see in epilepsy. This is what we see regularly. So I think the group decided, the group of neuropathologists who got together decided that late would be a better terminology, particularly since we now had antibodies for that TDP43 protein. So one of the keys aspects from a clinical standpoint, and sometimes you get lucky, is that there's that loss of episodic memory. But as I mentioned before, just like in part, semantic memory and verbal fluency seems to be preserved. And so this separates it from the semantic Alzheimer's disease that Dr. Salmon has done a lot of work in and published on very nicely, the semantic variant of Alzheimer's, as well as the primary progressive aphasias and the frontotemporal dementias. And I'll talk about that in a little bit. So it's very different. And even though we see TDP43 in people with FTD, we see it in FTD with ALS, we see it in ALS, we often see it in other rare dementias. You'll see this protein. It's very different in terms of onset. So you think about the age of onset of standard frontotemporal dementia, you're talking about people in their 50s and 60s, not in their 80s and 90s. The same to a great extent with all of the ALS cases, as well as those that come with FTD. So there is some dissociation of this protein. And when Pete and the rest of our group first published on this back in, I believe, 2011, there was a lot of pushback saying, we're seeing this abnormal protein, this TDP43, in FTD. How is this not a later form, if you will, of FTD? And so Yuri Katsumata, who's one of our biostatisticians, said, I'm going to look at the NAC data set and I'm going to determine what behavioral characteristics, since FTD has all of these behavioral components, what are the statistical models that predict, based on the behavioral variants, what the neuropathology is. And so what she did is she chose all the autopsy cases in NAC that had behavioral data and ran interesting cluster analyses that I couldn't explain if you put a gun to my head. But what we found as a group was rather fascinating. So the comparison or reference group are people with Alzheimer's disease. And we know that people with Alzheimer's disease have behavioral symptoms. There's no question about that. In fact, there's a paper that dates back to UCSD a number of years ago showing that 50% of people with Alzheimer's disease will develop delusions and hallucinations over the course of their disease. And so we see it in Alzheimer's, but we see it particularly in frontotemporal dementia. We also see it in Lewy body disease as a result of the alpha-synucleinopathy. But what's fascinating here is that analysis of the clusters, and I think I sent that paper so you can look at the details, is that you do get a distinct picture for those who have Lewy bodies, that's cluster 4. You see the FTD cluster, cluster 1, and cluster 2 is the part/late cluster with a very different clinical feature in terms of behavior as well as decline. And those of you who have run or seen patients with frontotemporal dementia really can appreciate the disinhibition and the language changes that you see in FTD. Whereas those of you who've seen people with dementia with Lewy bodies, particularly the early stages, you can appreciate how the hallucinations drive that clinical diagnosis, along with other things that I'll leave to Dr. Litvan, who's an expert in the area, but REM behavior disorder as an example, as well as postural hypotension. What's also interesting is that ApoE drives some of this association into cluster 3 and cluster 4. So with all of the autopsy tissue we have now, we're able to do finer grained analyses of these structural changes that occur in the brain of older individuals. And there's a lovely case example in German, believe it or not. This is me bragging on the fact that I used to be able to speak German. I think I lost my German ability after I lost my French language. So I don't know what that means for what my tau burden is, but they did a nice summary, if you will, of late and provided some imaging from kind of an index case. And what you're looking at is the CRAD battery, which was one of the first attempts to standardize cognitive assessment in Alzheimer's disease. And what you can see is that if you look at number 4 through, so 4 through basically 7 and 8 are verbal learning. So you learn a list of 10 words, you're given it 3 times and you recall it 3 times. And then after a delay, you have delayed memory. You can count intrusions in the delay. You can see how much the individual has saved. In other words, what was their maximal learning versus what did they remember 20 minutes later. And you can have recognition, which is this discriminability, if you will. And then they have visual memory, phonemic fluency, trail making. I guess the Germans can't change that. And you have Boston naming test, mini mental, and animal fluency here. And what's fascinating is you see a 1.5 standard deviation cutoff. You can see where the memory, particularly the delayed memory and the intrusions, are very abnormal, but you see that there's also learning that's being affected and some effect on overall global status on the mini mental. But note that the animal fluency is still within the normal range, as are some of these other frontal or executive functions that are there. And what they do, which is beautiful here, as you can see in the bottom panels, is they show with FDG PET that the hippocampi just aren't functioning. And yet cortical regions, if you look at panel 2 and 3, seem to be still showing good activity and explaining this pattern in a patient, along with, again, the loss of hippocampal function. So this is where the challenge comes now as we move the field forward. Can we use our neurologic tools or our radiologic tools along with our cognitive tools to identify these subtypes, if you will, of Alzheimer's disease? So again, I mentioned the Rush group, Bob Wilson. They published a number of years ago using their global index of cognition and showed that, yes, cognition declines as the pathologic burden of the TDP-43 proteinopathy increases in the brain. And they were able to model 10-year paths of this global cognition so that the higher the TDP, which is this lower curve, the more rapid the decline in global cognition. Note that if you don't have TDP, you're still declining, and that's probably because there's other pathologies that are present. And I'm going to show this same graph here, as you can see here, simplified, the high TDP-43 group, so that you can compare it with a study that was done a number of years ago with the NAC data, where we replicated an index that we derived for late. And essentially, what you see here is that if animal naming, think of that case study, that is relatively preserved in people who have no hippocampal sclerosis and no Alzheimer's, and who only have hippocampal sclerosis of aging. Whereas if you have AD neuropathology or both, you can see that the AD pathology plus or minus the hippocampal sclerosis or the TDP-43 late condition doesn't drive the semantic fluency task as much as it drives memory. And if you look at delayed memory, you can see that if you have Alzheimer's plus, those both depress your delayed memory score, whereas there's a little bit of saving here for those individuals who just have hippocampal sclerosis. And this replicated our initial finding, which was as the prevalence of hippocampal sclerosis pathology, and to an extent late, increases with age, and this is based on several thousand autopsy cases from the Nunn study, our UK cohort, the Georgia centenarian study, just to mention a few, is we see that the Alzheimer's pathology in the black curve begins to drop off in older ages, the prevalence, if you will, whereas the prevalence of this hippocampal sclerosis and late, this TDP-43 driven pathology begins to increase dramatically after about age 85. What's fascinating about this is that here are the curves of what's happening to global cognition. So the green line is you have Alzheimer's pathology and the hippocampal sclerosis or late. The red line is you have hippocampal sclerosis alone. And the blue line is you have Alzheimer's with no hippocampal sclerosis. And the black line is you have neither pathology. But what's impressive is that the late cases here hang in there with milder AD cases in global cognition. And what's really driving it is memory. So this is a delayed memory task. And you can see here's the AD course, here's the hippocampal sclerosis course, and then here's the general milder AD course versus normal. And then here's the fluency. And you can see, again, the green, the accelerated loss here. So what we did was we decided to look at a ratio between these two scores, and we're about 80% sensitive to the presence of late 4 years before we had the autopsy verification. So the Brenowitz study that I showed previously was a replication of this index that we derived to try to clinically identify late. Now, what's behind this? And this is a lot of work that Dr. Igohardo did, who was a MD PhD student with us working in Pete's lab and my lab. And she's now at Mayo Clinic, a wonderful lady, very bright and very capable. And this was part of her PhD dissertation, was to take a look at late and determine what drives late. The other people involved here are Dave Fardo, who's a statistical geneticist. And so Dr. Katsumata, Dr. Fardo, Dr. Nelson tried to look at some of the at the GWAS data and said, can we identify risk genes? And lo and behold, the ABCC9 gene became a risk gene for neuropathologically defined late. So what is it about ABCC9 that drives this? Well, it apparently has to do with the SIR2 receptor in the brain and potassium transport. Interestingly, because it's much more plentiful, the SIR2 receptor and those channels are much more plentiful in muscle, it was rather of a surprise. And there are lots of mutations that have been described on this gene for all sorts of different conditions, and you can read them on the slide. Particularly, what's impressive is the link to vascular or cardiovascular disease. And so the thought was, if that's the case, let's look at the brain of these individuals and look at their vasculature. And S.E. Igarato did a great job and showed that you will find this change in the small vessels of the brain that are associated with late. And they came up with this term, brain arteriolosclerosis, to pronounce it correctly. And she looked at it both clinically and neuropathologically. So here's an example of a normal arteriole to one that has multiple lumens and becomes very rigid. And she found that, yes, the ABCC9 gene variant is related to the presence and severity of this arteriolosclerosis. There may be other risk factors we don't know. There are some other gene variants that may drive this, but all of these appear to contribute to this TDP-43 pathology and hence memory loss. There's a lot in this. I think I sent that paper. It's well worth looking at because we also see TDP-43 proteinopathy in CTE cases, just in a different distribution. Finally, her work was very fascinating because she was able to go to the ADNI database and pull neuropathologically confirmed cases of late and look at the ASL to see what's happening to the perfusion in the brain. And lo and behold, those who had a non-risk phenotype or genotype, of the ABCC9 gene showed fairly normal arterial spin labeling and therefore flow in the brain, which is seen in panel A. But those who had the risk genotype for the ABCC9 and the BASC, if you will, risk, they showed reduced blood flow. So there are ways of viewing, if you will, the impact of the TDP-43 proteinopathy that can be detected using multiple methods. And as we continue to do work in this, and other groups are doing that as well, I think we're going to see more targets, if you will, for treatment. So one target based on Dr. Igarato's work easily becomes a target looking at ways to preserve cerebrovasculature as a way of reducing risk. So just to give you a summary of late, here we are, and we have part in here, cerebrovascular disease, through and Lewy body disease, and AD, based on some work we've been doing here. And of course, this fits the ATN profile for Alzheimer's. You got amyloid, you got tau, and you've got neurodegeneration based on CSF markers here. And you can see that in part, you see the high phospho-tau, and you see some elevation of total tau in CSF, whereas in late, you don't see the phospho-tau. You generally see the total tau, indicating that hippocampal loss, if you will. And interestingly, here's some data from our cohort, about 200 people, where you can see the A beta in CSF. Now, remember that as A beta goes down in CSF, you're more likely to have brain deposition, therefore an Alzheimer pathology. And as tau goes up, hence the yellow box, these are the Alzheimer's cases. These are the folks that fit the neuropathology of Alzheimer's. Whereas here we have people who have high total tau, but their A beta is not depositing in the brain. So they have the tauopathy. And so there are ways that we can use this information, I think. Not everybody likes to have lumbar puncture, of course, to clinically define this disorder. So very quickly, I'm going to bring up some history. Maybe it's because of my work with Dave Bennett in the early days on the religious orders study that I stumbled across this. And those of you who've been in science know this Occam's razor. Keep it simple, stupid is the way I look at it, but keep things reasonably, excuse me, I'm getting a message here. There we go. Keep things reasonably simple in trying to explain pathology, particularly disease. But there's a fellow that did get to spend some time at Duke. He ended up as chair of internal medicine at Indiana University, which has an Alzheimer's center, as many of you know, a fellow by the name of Hickam. And James Hickam was an interesting fellow, and he didn't like the Occam's razor approach to medicine. And so he coined his own phrase back in the 60s, which is this: patients can have as many diseases as they damn well please. And what we're discovering now with all of these new pathologic entities that we're finding, that's the case when it comes to the brain. Are we surprised? Probably not. But we've known this for a number of years. If you look at the Mayo autopsy series, you can see all the combinations: Alzheimer's plus vascular disease, Alzheimer's plus Lewy body disease, and so forth. In fact, Alzheimer's plus Lewy body disease probably years ago was seen as Alzheimer's disease with extrapyramidal features. And lo and behold, when you look at those comorbidities, forgetting about the clinical diagnosis, you can see what the major drivers are, and you begin to appreciate that Alzheimer's disease in its pure form is not as prevalent as we thought, even though as you add Alzheimer's with these other pathologies, you get back to that 70% figure that everybody talked about. But it's these multiple pathologies that are driving brain aging. And this is where Hickham's dictum comes in. When you look over at all of the possible combinations of proteinopathies, these misfolded proteins, you have what we call QMP, the quadruple misfolded proteins, which means you have alpha-synuclein, tau, A beta, and TDP43. Not a good thing. And you can see that 20% of the people who are clinically demented have this. But more importantly, we can see that there is a large driver in MCI, which is the essentially stage 1 to 4 plus A beta. And then we have the tau plus TDP accounting for some individuals, and tau alone. So these are the part and late components. And these lead to much more rapid, the more pathology you have, no surprise, the more rapid your decline. So we've squeezed it in. I just want to mention a few of our collaborators. And I've learned over the years that you can't do it all yourself. You have to have a good team that works with you. Pete Nelson, Jana Neltner are our neuropathologists here. Aaron Abner, our homegrown, if you will, biostatistician. This is Dr. Iguahara, who's now at Mayo, Dr. Fardo, Dr. Katsumata, and Dr. Criscio, who many of you may know, as well as the grants that have supported a lot of this work. And I can't do a talk on this without showing a picture of Bill Marksberry, who really was the inspiration to Pete and I in the early days by constantly coming into the lab or constantly coming into our office and saying, I've got this interesting case. Let's discuss it. I'm seeing a sclerotic hippocampus. I'm not seeing neuritic plaques all over the place. I'm seeing something different. And Bill sadly passed away over 10 years ago. And he was one of the originals, along with Bob Terry, Bob Katzman, and others who really pushed our field in the direction that it's headed. So I'll stop with that.
Yeah, again,
Quite all
terrific talk. Thank you very much, Fred, and hope to see you soon in person.
Well, I appreciate the invite, and it's good to see people that I haven't seen in person in quite a while. So thank you all. Thank you for the invite. And when I've got my Down syndrome talk in better shape, I'll come back and maybe do it in person, because
Yeah.
I miss my trip up to Stone Brewing.
Yeah, we'll take you out. So, all right.
All right. Thanks again,
very much.
everyone.